Okay, folks, shall we make a start? I think we're a couple of minutes past 11. We'll just get things underway. My name's Keith Hunter. I'm Professor of Head and Neck Pathology. I moved to Liverpool in the early part of this year. I'm a clinician. I'm a head and neck histopathologist, so I do half of my time across in pathology in the Royal, and I also run a molecular pathology of head and neck cancer research group. And so my job today is to cover certain elements, to give you, in many ways, a bit of an overview, bit of an introduction into the molecular pathogenesis of head and neck cancer, which is one of the main cancers of interest here in Liverpool. But I thought it would be useful, because I think it's helpful in terms of understanding the molecular pathogenesis, that you get a little bit of background about the disease itself. And I think that you will see when you come to the molecular pathogenesis in this kind of second half or the second two-thirds of the lecture, that you do need to understand the disease, the patterns of disease, in order to make sense of what the variety of the molecular roots to head and neck cancer that we actually have. So I'm going to spend a little bit of time just going a quick run through head and neck cancer as a disease, and then we'll come and we'll talk about the molecular part of it. But if there's anything that well, if I become overly complicated or anything like that, please do just stop me. Any questions that you may have, I'm happy to take them as you go along, and we can see how we go. Right, so here we go, slides. So when we're talking about head and neck cancer, what we're largely talking about are the mucosal cancers. So these are squamous cell carcinomas of the head and neck region. Now that encompasses everything really in the anatomical areas that you see on the screen. The vast majority of these are oral cavity. So they're going to be cancers of the tongue, floor of mouth, and so on. And the oropharynx, which is the area immediately behind your mouth, which encompasses the tonsils, the back part of the tongue, and the immediately posterior part of the throat, which is really just this part here. But head and neck cancer also includes cancers of the nose and the paranasal air sinuses. They are much less common. And it also includes cancers of the larynx, which are relatively common, and we actually do have quite a lot of patients with larynx cancer here in Liverpool. But the vast majority of really what we're going to talk about and going to concentrate on are cancers which arise in this area here, in the oral cavity and the oropharynx. Now this is, you may be surprised to know, a common set of cancers worldwide. Although it does not get the media interest that it should, head and neck cancer as a whole, encompassing all of these areas that I've talked to you about, is the 6th most common cancer worldwide. And so you can see the distribution here. In the UK, we have it doesn't come onto the top list at all. Head and neck cancer probably comes out about 8th or 9th overall in the UK. But there are certain areas in the world in which it is very prevalent, and that includes the Indian subcontinent. We're talking there about India and some of its surrounding countries and Sri Lanka. And the highest incidence of head and neck cancer, and largely oral cancer, is actually found in this pocket of the world down here, which is known as Melanesia. And there's something particular about the etiology of cancers in that area that I'm going to talk about briefly in a minute. But in fact, oral cancer is the most common cancer in males of any cancer in that part of the world. So a lot of the variation across the world relates to variation in etiological factors. It's actually quite high in some cases in Australia, but that's dominated by the fact that most of them are lip cancers due to sun exposure. What about in the UK? Well, it is one of the cancers which is rising in incidence and has been doing so for the last 2 decades and shows no sign of slowing down. So here we have data which runs from the mid-1970s through to about 2010, and you can see here the overall persons, which is the green line in the middle, and in males and females, you can see that the male rate is always consistently higher than the female rate, but both are rising. And then in terms of the subsites, again, you can see here we have them split down into the 3 main groups that I talked about, which is oral cavity, that's as mouth as you would expect, OPSCC, which is oropharynx, that's the bit of the throat just behind the mouth, and then larynx cancer. And amongst all of them, at all subsites, there is an increase. In some of them, particularly in females, for example, laryngeal cancer, it's relatively very minimal increase, but you can see particularly in cancers of the oropharynx across this 10-year period. And this is data from nationally from the UK, which was collated in Liverpool. You can see that it's rising really very steeply. And again, there are reasons for that I'm going to come to. But this is from the Independent last week. Again, there is now a lot of data and a lot of interest beginning to come into the media about head and neck cancer. And particularly, you can see here we're now introduced to this whole idea of human papillomavirus and what its role might be in head and neck cancer. And that is particularly related to cancers of the oropharynx. And that is why they are rising so fast. As far as the overall etiological group of etiological factors in these cancers, this is a very interesting infographic that CR UK have produced. And I don't know if you've seen that. You can download it from the CR UK website, but it covers the etiological factors essentially of all the main cancers in the UK and worldwide. And up the top here, it's got the main ones, which are breast, lung, colorectal, and prostate. And you can see in terms of the spread between male and female, the etiological factors which are related to environment and which are related to other factors and so on. And oral cavity is down here. Oral cancers are here. And so you can see here blue, as the blue part is bigger than pink, more males than females. The big bands relate to environmental exposure. The fine bands, the thinner ones, relate to other factors, perhaps inherited factors or unknown factors. And almost all of the risk associated with the development of oral cancer is related to environmental factors. And that is largely tobacco and alcohol. But there are a number of other things which play into that, including poor diet and obviously infections, which I'm going to talk about. So it's largely a disease across all of the head and neck sites of environmental exposure to carcinogens. And these are the two main culprits still, tobacco and alcohol. And they are synergistic. That means if you smoke and drink, that you will have a multiplicative effect on your risk. But that's not the case across the world. And here we see that this is actually a very common sight. This is a photograph I took myself on the streets of Delhi of a pan seller. And they are selling a particular, this is what they call the pan here, and this is being made up, includes areca nut, often tobacco, various other spices. And this guy here is making them up really to order, exactly the way you want them to be made up. And the combination of tobacco and areca nut, which is the fruit of one of the palm trees, is incredibly carcinogenic. And these little packages that are made up here are folded up and then are put in the mouth, very often in the cheek, and are held there for a considerable amount of time. And it gives the pattern of oral cancers, often in India, Sri Lanka, and these surrounding countries. They're very common in the cheek, which is not something that we see in the UK. You'll notice there's a whole load of packages on the fence behind there, and as if you don't have time to get one to made up to your own specifications, you can buy pre-packed ones. On the other screen, and I think this is not, unfortunately, I have put photographs over, you can see here of other smokeless tobacco products. But this guy in the background here, whose teeth actually are bright red, is one of the folks in Papua New Guinea who have the highest risk of oral cancer, and they also use areca nuts, but they use it in a particular way. They combine it with coral and lime and the stamen of a particular plant there, and it is perhaps the most profound carcinogenic cocktail which any of the communities across our world inflict their oral mucosa, and hence the risk of oral cancer in these communities is the highest of any in the world. Smokeless tobacco is available in Western countries. This is snus, which is the Scandinavian version of smokeless tobacco. You get little tea bags of it held under the lip here. And I was in Scandinavia examining a PhD earlier this year, And I was really surprised to see how even amongst the medical and dental profession there, that they will still use this. And it is, although the risk is much reduced, it is still associated with an increased risk of oral cancer. Alcohol too, very important. The patterns of disease over the last few years, where we know in society that smoking rates are coming down, lung cancer rates are on the way down, but oral cancer, as we have seen, is increasing. So that means it cannot solely be due to tobacco. And alcohol plays an increasing role. And in fact, the rates of rise of oral cancer matches much more closely the rates of rise of cirrhosis of the liver, which may indicate that in fact alcohol is playing an increasing part in the risk of developing particularly of oral cancer. And then that brings us to human papillomavirus, which is the new kid on the block, essentially. Although I say that, it's something that we have been very well aware of for about the last 20 years or so. Now, these are cancers which are a specific subsite in the head and neck. They're tonsil cancers or the base of tongue. They are oropharynx cancers. And these are sites where there are mucosal lymphoid tissue. And these patients there get HPV-associated cancers. And it's the same oncogenic subtypes, largely, of human papillomavirus that cause cervical cancer. And it's now pretty well established that, in fact, the transmission of HPV into cancers of the oropharynx is sexually related. You will perhaps have noted over the last few years that there are a number of celebrities who are talking about their oropharynx cancers. Many of them in the film industry or music industry. Bruce Dickinson was relatively recent, the lead singer of Iron Maiden. But there was a large fuss a few years ago about Michael Douglas talking about this. He was very candid in his interview with The Guardian about how his lifestyle contributed to the fact that he got probably a huge amount of combination of tobacco, alcohol, and human papillomavirus. He knew how to live life well, so he would say. But you will not find that interview anywhere. It was very quickly taken down by his publicist. The oropharynx rates, again, as I showed you earlier, are increasing. But in fact, in this UK data, it's not just the human papillomavirus variants that are increasing. The smoking and alcohol ones are as well. So what about this head and neck cancer largely as a disease? Now, I know we're a little bit away from lunch. There are a few clinical pictures in here. So if you're a little bit squeamish, you can stick your head down if you want. But we do have these lesions. They develop, some of them through precancerous lesions, and then they grow into primary tumours, and then they spread. And that gives, obviously, a variable prognosis for the patients. So in some of the patients, I have a particular interest in the precancerous lesions, which affect the oral cavity particularly. And these tend to be white or red patches, or mixed white and red patches. We call the white patches leukoplakia, red patches erythroplakia, which just means white patch and red patch. And these are lesions in the mouth that come with an increased risk of development of oral cancer. Does not mean that if a patient has these that they are going to get oral cancer, but they are there because they give an increased risk, and they are associated with the risk factors of tobacco and alcohol largely. And we biopsy these. A large part of my practice is looking at the biopsies of these precancerous lesions, and we grade the abnormality in them. We call that abnormality dysplasia. And the extent and the severity of dysplasia is related to the risk in that patient of them then going on to develop oral cancer or larynx cancer or wherever their pre-malignant lesion might be. And so we're tending to move along this continuum here of normal, often through a bit of hyperplasia, and then dysplasia, and eventually, in a proportion of these patients, perhaps they don't moderate their risk factors, they will then develop an invasive squamous cell carcinoma. So here are some of the examples of our primary tumours. You can see these are particularly oral cavity ones. The one on your left here is a lesion from the floor of the mouth in a patient who has lost their teeth. They are edentulous. So this is looking at the floor of the mouth and the underside of the tongue. And there is an ulcerated raised lesion. And then you can see on the right an even more advanced lesion, which is a large exophytic ulcerated mass on the lateral border of the tongue. And it is always astonishing how, to me, even having been involved with these patients for the best part of 25 years, how patients just allow these lesions to get so large. But they do. And then, in this one here on your left, you've got a tumor on this patient's left tonsil, as you can see. You can see the asymmetry which is there. There's a large mass extending from the left tonsil. And then in a patient who, this is a fiber optic view down a larynx, down to the vocal cords. And this patient actually has a white patch, as you can see here on the left vocal cord, and this was a very early squamous cell carcinoma. So that's the type of lesions that we can get. They vary in size, they vary in extent, from some which are very small to incredibly large tumors, which unfortunately we have to deal with through our cancer MDT. The vast majority of them in terms of their pathology are squamous cell carcinomas, and the classic type. Virtually all of them are that. But there are some other types. On the picture here we have what we term a verrucous carcinoma. It looks like the patient's got a kind of creamy white carpet over all the roof of their mouth, and it almost feels like it's got little hairs when you run your finger over it. It's quite a freaky thing to experience clinically. And these are actually generally low-grade cancers associated again with tobacco use. But there are also more aggressive subtypes histologically, like basaloid squamous cell carcinoma, spindle cell carcinoma. Spindle cell carcinomas are more common in the larynx, which are more aggressive, and the patients will have a poorer prognosis. And then there's a scattering of others, which I'm not really going to talk about: salivary gland cancers, lymphomas, melanomas. You get melanomas intraorally or up the nose, as well as on the skin, and various soft tissue tumors. And this is histologically, again, what I would spend part of my life looking at. This is an invasive squamous cell carcinoma. We have islands of squamous epithelium with keratin in the center, but they're invading. These broad pink stripes here are muscle. So these are islands of squamous epithelium in amongst the muscle of the tongue. So this is definitely invasive. It's definitely a squamous cell carcinoma. The next step beyond that is that the tumors will spread from their primary site, most likely into the lymph nodes of the neck. And so there are chains of lymph nodes which run down the main muscle that runs down the side of your neck, the sternomastoid muscle, and these are the primary sites of initial metastasis from head and neck cancers. And that's whether they are nasal, oral, oropharynx, larynx, and so on. They all spread into the neck. The tumors, you can see here, this is a patient who's got a lump in the upper part of the neck, and histologically this is what it may look like. Lymph node round the outside here, and then islands again of squamous carcinoma in the lymph node. And eventually, if that's left unchecked, it will grow to take over the whole of the lymph node, and then will break out of the lymph node into the soft tissues of the neck. And so lymph node metastasis is a sign of poor prognosis for patients. But if you get what we call extranodal extension and it grows out into the soft tissues of the neck, that's an incredibly poor prognostic factor. Excuse me. So how do we treat this disease? Primarily by surgery. Certainly for oral cavity. Yes, I don't want to put up a whole set. I'm sure others who maybe teach you, like Professor Shaw, will probably show you a whole series of gory pictures. But it's a patient who has a cancer here in the back of the tongue, and they're opening up, they've split the jaw to get access to that. And then they remove the cancer, they put it back, and this is the patient after a few months, and you can see that essentially there's a good result from that. The surgeons can do amazing things in terms of being able to reconstruct these defects that they produce in removing the cancer. Radiotherapy is a very important part of treatment, and that includes new versions of radiotherapy, including IMRT, which you know what IMRT is, intensively modulated radiotherapy. It's a new type of being able to control the intensity of the radiation beams. And that's particularly important in the head and neck because you want to be able to irradiate the cancer, but there are so many things around your head and neck you really don't want irradiated. And one of the biggest problems that you have after irradiation to the head and neck region for cancer is that the radiation has effectively destroyed the salivary glands. And that means that the patients end up with absolutely debilitating dry mouth. This is not the dry mouth you get after a night out. This is seriously no saliva at all. And so IMRT helps reduce that, and also proton therapy. There's a proton therapy facility across in the world, and again, we're beginning to use that in our head and neck cancer patients. For advanced cancers, or for patients who have oropharynx cancer, we tend to use chemotherapy in addition to radiotherapy. This is largely cisplatin-based, because that's the most effective treatment. And for patients with oropharynx, HPV-associated oropharynx cancers, they are incredibly chemoradial sensitive. And so in fact, for many of the oropharynx cancer patients, their survival rates are really, really good. And that's the main use of chemotherapy in head and neck cancer. And then we come to the thing which I guess just brings us into the molecular aspects of head and neck cancer and targeted therapies, biological therapies. And you will see that, in fact, the list of those which are routinely available is incredibly small. In fact, that's it. There are a lot in trials. And this is one of the problems with head and neck cancer, as we will see. Molecularly, it's incredibly heterogeneous, which means that it's been very difficult to get consistent new targets for therapy. We'll talk a little bit about EGFR as we go through the molecular aspects. This is cetuximab, as I'm sure you're aware of, which is anti-EGFR therapy. And this has been somewhat successful and useful in some patients with head and neck cancer, but it's not really given us a large increase in control of these cancers. And then immunotherapy. Pembrolizumab is the main immunotherapeutic, and we'll talk a little bit about that in a while in terms of the tumor microenvironment. So before we step into the molecular aspects, just a quick run through. What are the main problems in head and neck cancer? Why is it important that we understand the molecular pathogenesis? What are we trying to achieve? There are certain aspects of it which are perhaps not in the remit of looking at it from a molecular point of view. The first of these is most patients present at advanced stage. So the real thing which perhaps would revolutionize how we treat our head and neck cancers is actually getting patients to come in earlier. If we got them at an earlier stage, we would massively improve survival. But recurrent tumors, and that also means therapy-resistant tumors, how we understand the molecular aspects of that, and that's a particular interest of my own group. The fact that patients develop new tumors, and I'm going to talk about the molecular basis of that in a minute, and the fact that we are desperately needing new targeted therapies. So that's just a quick run through head and neck cancer as a disease. I've skipped over a whole load of bits and pieces, but I'm happy to take any questions that you might have at this point. Everybody happy enough? Any questions? Okay, fine. So I'm going to move in to talk about the molecular aspects of it. Now, there's a certain extent to which, in the molecular aspects, there's a lot of overlap with every other cancer. In terms of the capabilities that these cancer cells, these squamous cell carcinoma cells, acquire during the development, there's a lot of overlap. Certainly a lot of overlap with skin, but in fact, cancer processes across almost all cancers. So this is bringing together a lot of these particular molecular features, and we could go around them and spend a couple of hours looking at all the different features in relation to that. Some of this has come out of Hanahan and Weinberg's original hallmarks of cancer paper, sustaining proliferative signaling, that is largely the switching on of oncogenes, evading growth suppressors, the knocking out of tumor suppressor genes, and so on. I'm particularly interested in senescence, which is the inherent growth limits on cells and how they are bypassed. But there's a lot here in terms of areas of interest for a lot of us in the head and neck cancer group here. So this is the basic model of the molecular pathogenesis of head and neck cancer. So I'm just going to take a little bit of time and step through this. So here we have at the bottom, I showed it earlier, there's this continuum of histology which changes eventually going from normal through what we would term dysplasia histologically to invasive tumour and then eventually to metastasis. We know that there are some very early changes. So that this bit in the centre here, which covers the HPV negative and high SYN tumours, this is the sort of standard pathway. And you see here that very early we have alterations in P53, as we will see when we start to have a look at the sequencing. And in fact, this is really the most consistent molecular pathway which is altered in head and neck cancer, and it happens very quickly, and we can demonstrate alterations in P53 at pre-cancer stage pretty convincingly. Then stepping on from that are a number of other alterations, primarily within the cell cycle. The removal of P53 allows the cells then to continue with abnormal DNA, but there need to be other alterations within the cell cycle to bypass other growth limits. And for example, the loss of P16, which is very often done by methylation initially, but then is either deleted or mutated to make that permanent. And so you then get this background here very early in pre-cancer of altered cell cycle proteins, which are going to give a proliferative advantage. On the background of this is increasing genomic instability. And so you then get an increase in the abnormalities as these cells with abnormal DNA are allowed to continue to divide and to copy their altered DNA into their progeny. There are abnormalities in TGF-beta signaling at this point and other signaling pathways, including the SMAD and NF-kappa B, which extend through other signaling pathways by the time you get to invasive tumour. And so during this point, there is increasing genomic instability, and the cells will become aneuploid. So you begin to get abnormalities in the karyogram, not just individual mutations, but abnormalities in copy number and in chromosomal number as well. So the feature it pictures here is a P53-driven cancer development, which results in increasing genomic instability and the development of the invasive cancers. Now, I talked about the fact that human papillomavirus is an important other etiological factor in head and neck cancer. And that is the case. Well, you know that human papillomavirus produces a number of oncoproteins, and the main ones which are of interest are E6 and E7, and they do a lot of different things within the cells, which I'm sure you may cover in other contexts. But for example, E6 protein will knock out P53, and E7 protein will knock out RB. So that means that these background facilitating changes that we need to get early are also undertaken by various proteins which are produced by human papillomavirus. What you don't get in that regard, though, is mutated P53, which becomes insensitive to therapy, and that's why HPV cancers tend to retain quite a lot of their chemo and radiosensitivity, because the changes are being driven by the proteins that are being produced by HPV. So that is molecularly distinct, and again, we'll see that as we go through some of the sequencing data. Then there is a group here which we've been interested in, well, I've been interested in for a number of years since my PhD. And that's those which are HPV negative and those that have got a very low mutational and copy number change abnormalities, low CIN. We don't really understand them very well at all. And it may be that these patients will do better histologically because they don't have a lot of these molecular changes, but there's a lot of interest in these, and we're trying to gather together cohorts of these patients. Now, as I indicated, there's a particular biological phenomenon which is molecularly based, which is very important to understand in terms of head and neck cancer as a disease. And that is this concept of field cancerization. So we've looked at a number of these molecular abnormalities, be they related to chromosomal loci or individual genes. And what tends to happen in a patient who is a smoker is that they will get a wide range of these abnormalities across the epithelium which lines the upper airway digestive tract. And so in some areas, for example, you might then, so the light blue here is, if you like, your pre-cancer, your dysplasia part, okay, so the early changes. And focally within that area of dysplasia, you might get progression through to stages where it becomes invasive and it then becomes a cancer. So that's our primary cancer. And the box here indicates what the surgeon has done. So the surgeon has come along, has removed the tumour with a bit of a margin at the edge here, hopefully removed a bit more than just leaving some cells behind, but that sometimes happens. And so what happens then to these patients is interesting. So it may be that taking the tumour out, that you get a cure. And that's fine, and for a lot of patients you do. But what happens if you leave a little bit of this genetically abnormal field behind? Well, of course, exactly what has happened here can then happen here. So you then actually get a patient who then develops what we call a second field cancer. So 20% of patients who have head and neck cancer will develop a second primary. And that can be anywhere within the mouth or even actually down into the lungs. You might get recurrence of tumour if the surgeons maybe left a little bit of the tumour behind. But then, particularly if the patients actually continue to smoke, for example, they might actually gain a new bit of field, a new genetically abnormal field, and again, you can get the progression of an independent field, which is a true second primary tumour. Most patients probably get a second field tumour. And so the concept of field cancerization, a large field of genetically primed epithelium, is a very important concept in understanding how molecularly oral cancer, head and neck cancer, progresses in patients. And if you're looking for a paper to pick up just to have a look at the current ideas in head and neck cancer, molecular pathogenesis, very layman's paper in Nature Reviews in Cancer, is one just to pick up. You'll get the main messages from that one paper. So as I indicated, there are common pathways in head and neck cancers, whether they be HPV positive or negative, but the molecular detail of how the pathways are altered differs. So here we have, again, human papillomavirus. E6 degrades P53, E7 affects P16RB, and then there are further abnormalities after that. Whereas the HPV negative, as I showed you in the other diagram here, we have this sequential mutational background which alters all of these pathways. And the end result being, by whichever pathway you get, that you get a head and neck squamous cell carcinoma. So this going to step down through the cancer genomes, if you like, of these and see what they have to say to us. So overall in head and neck cancer, this was a large study looking at the copy number variation that we get in head and neck cancers as they develop. And you can see here the extent of copy number variation across the cancer genome in head and neck cancer. We're getting large areas of gain and loss. Tends to be fairly reciprocal. You may get gain in one arm of a chromosome and loss in another. You get particular spikes in some areas. For example, in the chromosome 17, which are where P53 is, where you're not going to get particular spikes of loss. And areas particularly, the likes of 8q and so on, and 18p. 3q tends to be a very common early site of loss. And this relates very much to some of the important genes that we've been talking about. And this is consistent. And although it's perhaps not quite as extreme, we've done karyotyping like this on pre-cancer, and it shows a very similar type of pattern. So you're getting these fields appearing, and the genetic abnormality appearing at pre-cancerous lesions. So what about the mutational landscape? And there were two papers came out in the same issue of Science back about 10 years ago, which are very interesting and have set the landscape for us, in which for the last decade we, as head and neck cancer researchers, have largely been working. So here we see, across this group of patients, the mutational load. And you can see how it actually varies quite considerably from patient to patient. Some have really very high levels of mutational burden, but in general it's a fairly moderate level. We know that, and again, we've got a number of HPV related cancers in this cohort. And what you generally find, if you match these up, you'll find that the HPV positive ones, generally speaking, have a much lower mutational burden. And that is because of the biological reasons that we've talked about, that the early changes that you get are not driven by the mutation of P53 and an increase in genomic instability. You tend to get the mutational rate in HPV-associated cancers will begin to increase later in the development of the disease, but it very much lags behind those in patients who have got smoking and alcohol-related cancers. And overall, really, if you were to compare this, the top graph with, say, for example, smoking-related lung cancers, you would find that the mutational rate is very similar. And in fact, the pattern of the changes which are present are very much related to, are very much smoking-related. So which genes are particularly mutated in head and neck cancer? Now, this is where the molecular heterogeneity of head and neck cancer becomes very apparent. And this is the list of the top genes here. This was, again, from the TCGA. It was published in Nature in 2015. But we've now got some very similar data from the 100,000 Genome Project. And it shows that there is one very common mutation in head and neck cancer. Surprise, surprise, that's P53. And 72%, and I think once you add in probably another handful of abnormalities within the P53 pathway, that is the dominant molecular feature of head and neck cancer. But then you struggle to get beyond that. You know, for example, in terms of the sequencing and also those which come up in the COSMIC database, you see very few of them. In fact, CDKN2A, that is the locus which codes P16 and P14, mutated in about 22%, FAT1 23%, and PIK3CA, which is particularly of interest in HPV-associated cancers. But nothing really is getting above 20%, so we don't really have a very consistent mutational profile that you could, for example, go after in terms of developing novel therapies that would give you something that would be of use to the majority of patients. It's only P53 which seems to be fairly ubiquitous. And so this pattern of mutations with, once you get down here, you're talking about mutations in 5% of cancers and so on. That's not anything that any pharma company are going to take up as a good target for therapy, because if it's only going to be useful in 5% of patients. So this has made life very difficult for us. But as you can see, for the PIK3CA, these ones at the end here are HPV related, and you can see the proportion of them that have that mutation. That is very interesting biology, which we don't have time to go into today, but it's another research interest within Liverpool. So we then bring in the oncogenes as well, and here we come back to EGFR and other changes such as those in cyclin D1. You can see that, again, the molecular background is pretty heterogeneous. So I talked a little bit in the treatment section about the use of cetuximab as anti-EGFR therapy, but amplification of EGFR only occurs in probably about 15% of cases. So that may limit the use of cetuximab in head and neck cancer. Of course, we know that amplification of EGFR is not the only molecular abnormality in the EGFR pathway that's interesting and important for targeting. There are mutations in other pathways and so on. But that, I think, exemplifies why EGFR inhibition has not found a really large and important role in the treatment of head and neck cancer. Cyclin D1 is the most commonly amplified oncogene. It's in about 30% of patients. Again, the HPV negatives largely. And we see the abnormalities in PIK3CA scattered across HPV negative and particularly HPV positive. So this is where we have a bit of an issue in terms of the molecular heterogeneity of head and neck cancer. So this is a summary really of where we are with a lot of the important changes, things that a lot of people have been working on. Some of us here in Liverpool, we're going back to have a look. P53, because of its ubiquitous nature, really sort of fell out of favour in terms of being looked at for therapeutic targets and so on in head and neck cancer. But we're at the point of putting in a large grant here to look at that again, and we've started some work in the lab, including in one of the master's projects this year, having a look at that, and particularly p53 isoforms and what that might be telling us about how these tumours will behave and respond to therapy. EGFR is interesting in terms of therapeutics, but as far as something which is widely applicable, not so much. PIK3CA is very interesting, particularly in HPV-associated cancers. And there are various others. And the epigenetic regulation is again another very fertile area, which I'm not going to go into in any detail, but Professor Shaw, I'm sure, will cover that with you in another lecture. So if we bring together all that molecular data, what do we get to? Well, we get to a schema, again, this is from Benny Lehman's paper from a few years ago, of what we understand about the molecular pathways and subgroups within head and neck cancer, which may be the way forward for us to stop treating head and neck cancer as one disease, but to actually molecularly segregate it, and that might give us an idea of where we can get novel therapies. So we know that, here we are in normal oral mucosa, and there are three main pathways. There's the HPV positive pathway, and biology of HPV E6 and E7, and then the interesting group of which have mutated PIK3CA. So that's the HPV-related arm and the main interest in that area. Then there are the classic smoking-related ones, driven by p53 and p16 CDKN2A abnormalities through a field cancerization process to cancer. And we're now beginning to split these into subgroups related to their transcriptome, basal, classical, and mesenchymal, and I'm going to talk about that in a minute. And then there is this group which is copy number largely neutral, probably has abnormalities, caspase 8 and so on, and this is the rather enigmatic group that we really don't understand very well. So again, in this TCGA paper in Nature a few years ago, they started to have a look at the transcriptomes in terms of being able to molecularly segregate head and neck cancers into a number of groups. And in fact, this is agnostic to site to some extent. You can see at the site on the head and neck, whether the oropharynx, oral cavity, larynx, or hypopharynx, they're all included in this. And so the molecular features tend to transcend to some extent the sites. And so they separated on the basis of transcriptome and mutational features into four main groups. The classical type, oxidative stress and smoking associated, as you would expect, p53 mutated, and profound abnormalities in chromosome 3q, amongst other abnormalities. Then there is the atypical. The atypical ones is largely the HPV positives. And whilst many head and neck cancers have abnormalities in chromosome 7, this group doesn't. And then in the mesenchymal variant here, again, this is perhaps the largest single group. And this is dominated by a group of genes which are primarily from the tumor microenvironment. Now, that's something I'm going to talk about in a minute. And particularly, innate immune genes. And a lot of these, the mesenchymal ones and the basal ones, which is the other group, notch mutations and so on, these two groups tend to do very badly. And so these are aggressive tumors. And you can do the same actually with the epigenome. And again, I'm not going to talk about that, looking at patterns of hypomethylation, hypermethylation, and they separate into groups as well. You can look at that in the original paper. So that does bring us to the tumor microenvironment in head and neck cancer. We've talked largely about the genetic features of the cancer cells, but a lot of the progression of head and neck cancer is driven from the tumor microenvironment. And that includes the group of cells you can see. So here's our cancer cells, but we have fibroblasts, we have myeloid cells, lymphoid cells, blood vessels, including endothelial cells, and the components of the extracellular matrix itself, which are important in terms of the progression of these cancers. Now, I have a particular interest in cancer-associated fibroblasts and how they determine the progression of these cancers, and also how they are very important in the development of resistant to oncological therapies. And fibroblasts are a very interesting group of cells. There are some tumor suppressive effects related to fibroblasts, but largely once you get primed cancer-associated fibroblasts in a developed tumor, they are tumor promoting. And so they will promote chemoresistance, cancer cell proliferation. They are proving to be very important in local immunosuppression. So, for example, a tumour which has got a lot of cancer-associated fibroblasts will tend to be very resistant to immunotherapy. And then related to development of blood vessels and invasion and the remodeling of the extracellular matrix, which is very important because the extracellular matrix captures a lot of growth factors that when they are remodeled, they are released into the tumour microenvironment. And this contributes to promoting a number of the cancer hallmarks, as you can see here, largely through secretory methods. So these are HGF or c-Met, and other prostaglandins, interleukins, and so on. These are all secreted. This is a document, a picture that's come from a hepatic carcinoma thing, but again, it just reinforces just how important fibroblasts are within the tumour microenvironment. And I wanted to put this up because it shows you really that they come from a whole variety of different sources. They can come from mesenchymal stem cells, they'll come from resident fibroblasts in the area, and so on. So there's a lot of plasticity within the fibroblast populations in tumours, which give rise to all of these effects. They are activated by a number of different pathways. And we're now beginning to see that, again, just as we could see with the cancer cells and their features, that there are molecular subtypes of cancer-associated fibroblasts, and that they are doing different things in the tumours. And again, there's this balance between tumour suppressive and tumour promoting effects, which is very important. So, well, how does that manifest itself in cancer? Well, if you take a marker of fibroblasts, the basic marker that we tend to use is smooth muscle actin. That is indicating that they have become activated or myofibroblasts. We stain the tissue sections with smooth muscle actin, and then we have a look at the level of expression of that and relate it to prognosis. In oral cavity cancer, that predicts the outcome for the patient far better than any of the clinical parameters, stage, or anything like that. So this is a very simple test of something in the tumour microenvironment is very profoundly associated with poor prognosis. So if you have a lot of these activated fibroblasts, then, for example, SME high, your survival is only about 20%. If you are SME low, that means you've not got a profoundly myofibroblastic tumour microenvironment in your oral cavity cancer, then your survival, and we're talking about out to 10 years here, is 80%. And so you can see just how much of this in terms of outcome is related to the microenvironment. And these CAFs are now being separated into individual subtypes. The immune and desmoplastic CAF subtypes are largely helpful. They're good fibroblasts. They're those that primarily have got the kind of wound healing type appearance to them, and they are generally quite useful. We're now seeing very contractile CAFs. That's those that are expressing a lot of alpha smooth muscle actin. And aggressive CAFs, they may be related, it overlaps into features of senescence, which they are producing large amounts of cytokines into the tumour microenvironment. And so these two types that we are particularly looking for, and we're looking at in terms of function in head and neck cancer and cell culture, are very important. And we can understand how these are functioning and we can intervene in them. The immune microenvironment is also very important. This was some work that we published a few years ago in Journal of Clinical Oncology, looking at the transcriptome of a whole range of head and neck cancers. And these are the three groups of genes which were most closely associated with prognosis. This group here had the highest, if you like, fibroblast-associated signature when they did the worst. You know, that's essentially what we saw from the alpha SMA expression. But also, interestingly, elements of the immune response also dictated prognosis. If you had primarily an adaptive immune response, that is primarily T-cell driven, cytotoxic T-cell driven response, you did a lot better than if you had primarily an innate or non-specific response to the tumours. Again, that makes sense in terms of the biology. And so the patients who did worst of all are those who had a high myofibroblast component to their tumours and had very little adaptive immune response. As I said earlier, fibroblasts tend to exclude T cells, which makes them very resistant to immunotherapy. And so that gives us a favorable environment where you do get access of cytotoxic T cells into the tumour so you can get anti-tumour immune responses. But if you've got an unfavorable environment, in this case lots of CAFs, the T cells are kept out of the tumours and you don't get a good immune response to the tumour. And Professor Christian Ottensmeier, who I work with, this is his area of research, and there's a lot of good research going on at the moment in Liverpool related to that. An important part of it, again, I'm sure we talked about this in other contexts, are the functions of the immune checkpoints, for example, PD-L1 and CTLA4, and how in the tumour microenvironment, if these are expressed, that effectively switch off T cells. And again, pembrolizumab, as you can see here, it's an anti-PD-L1, is going to break that interaction and allow the T cells again to perform the cytotoxic functions. And that is the basic principle behind immunotherapy. But of course, immunotherapy is not an awful lot of use if you don't actually get T cells into the tumour in the first place. So again, taking it back into our patients, lymphocytes, is that important? Well, again, you can see here in HPV positive and negative tumours. These patients who are HPV negative, that's the smoking-related cancers, who are TIL low, they have a low tumour infiltrating lymphocyte count, their prognosis, their survival is 40%. But if you have, for example, an HPV positive, which tends to have a good prognosis anyway, and lots of tumour infiltrating lymphocytes, well, then your survival is probably 85 to 90%. So you can see just how much this does play a part in the survival of these patients. What about other aspects of the tumour microenvironment? Well, I've talked briefly about the extracellular matrix. It's very important. There are very growth factors in the tumour microenvironment, but in fact, components of the tumour microenvironment itself are very important in allowing the progression of these tumours, as are other cell types, which we don't really have time to go into. Endothelial cells from the neoangiogenesis of these tumours, neurons and adipocytes. But related to that, I just wanted to highlight something which, again, you will probably be taught on a more conceptual level, but that's the whole idea of the importance of tumour hypoxia. And the development of the neoangiogenesis in tumours, providing a blood supply. And of course, those tumours which are very well oxygenated don't tend to be as aggressive as those which become very hypoxic. And hypoxia itself, as the tumours grow and expand and their oxygen tension reduces, that switches on a whole number of different features which reduce tumour antigen presentation, increase the function of immune checkpoints, genomic instability increases, and we get a switch on of a whole manner of signalling pathways which are generally going to make the cancer progress. And so again, we're looking at being able to modulate hypoxia in tumours. There are a number of trials ongoing with that at the moment. So this will bring us to an end. Well, what about, where are we going with head and neck cancer? Well, there's always the question of, is the HPV story time limited? A number of you here will have been vaccinated, not all of you. The guys, I'm afraid, you were lagging behind, but we're now vaccinating everybody. So that might mean the HPV story is time limited, but it's going to run out of steam, perhaps at some point in a generation. The molecular aspects of it might mean that we're heading towards treating head and neck cancer as more than one disease. And we know that we're going to be increasingly looking at the tumour stroma as we try to develop new treatments. So that's all I have for you, and I'm very happy to take any questions that you may have. And as always, if any of you are interested in this from a research point of view, I'm very happy to talk to any of you about that as well. Silence. Is that stunned silence, or is it not a word of that was completely intelligible by this mad guy with a Glaswegian accent, or everything okay? So if you're on review of it, have a look at it, come back to me with any questions that you may have, and thank you for your attention. And I will stop the recording now, and